Hello, welcome everybody. We are so excited to have you with us today as we discuss one of our new Bree reports on the first episode psychosis. My name is Emily Noodleman, and I am the Director of Implementation and Outreach at the Bree Collaborative. During the presentation today, we'll provide an overview of this new report, hear from some individuals representing different audiences within our healthcare ecosystem on how they intend to implement the guidelines in their role or may already be doing so. We'll then transition to learning a little bit more about our evaluation framework and wrap up with a Q&A with our speakers. If you have any questions for our speakers today, please place them in that Q&A box at the bottom of your screen, and we will be working on asking them on your behalf. The webinar today is recorded, and we plan to send out a PDF of the slide deck and the recording to you via email. We'll also post it on our website if you want to share it with others. We want to provide a little bit of an introduction to the Bree Collaborative. It was created in 2011, and we have been here for a little while creating different reports trying to improve health outcomes for Washingtonians. Each year, the Bree develops reports on key health topics facing Washingtonians, and our members who are appointed through the governor's office identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, that have patient safety issues or inequities. For the majority of these topics, we form a work group of subject matter experts and leaders developed evidence-based guidelines. These are individuals all across the state who are really passionate on these topics, who are kind enough to provide us with their time, knowledge, and expertise to help craft these reports. These guidelines are actions that can be taken to improve healthcare for a specific healthcare service, really taking into account existing quality improvement programs and the work being done by other organizations. Our reports provide guidelines for multiple audiences, such as clinicians, health delivery systems, plans, purchasers, sometimes the Department of Health, Healthcare Authority, a lot of different audiences, but we really want to encourage collective action to promote optimal health for Washingtonians. If you're from out of state, you also can use these reports. We just kind of tailor it to the state of Washington, as that is where Bree Collaborative is focused on. The Bree Collaborative, again, forms these work groups to bring individuals to craft the report. And we just want to take a moment to share that we really greatly appreciate our work groups members' willingness to share their time with us and provide us with that support. And today we are really looking forward to hearing from them and share this with you all. We hope by the end of the meeting today, you will leave with greater knowledge of the Bree Collaborative and learn more about how we can promote individuals experiencing a first episode psychosis in our state. Our speakers today are Darcy Jaffe from the Washington State Hospital Association. She's kindly served as our chair of this work group for the past year. We have Dr. Franz from Cambia Health Solutions and Regents, Sunny Levin and Allison Schwartz from Harborview Medical Clinic, and our own Carrie Nicholas to talk about evaluation. As we jump in today, we want to just provide a little bit of an overview and an introduction to this report. Like I mentioned, it is accessible online, and we can drop that link in the chat if anybody would like to review that. But again, you can access this later too. But I really would like to pass it off to our chair, Darcy, to provide a little bit of overview of why, as a Bree member and the other Bree members chose this as a focus of the topic, and some more information about the focus of this specific report. So I will welcome Darcy.
Great. Thank you, Emily. And thanks to all of you that are listening to us today or will listen to us later in the recording. As Emily said, every year we have multiple topics for consideration, and we choose 3, occasionally 4 topics to create guidelines for in the following year. When we considered first episode psychosis, we really did look at how it is affecting the mostly youth of Washington, although you'll hear that the age of first episode psychosis can be a little bit older occasionally. And wanted to see where we had gaps and where we could do better. This particular topic rose to the top of the 3 topics we did it last year, and I am confident that the guideline it's very comprehensive. It has all the tools that clinicians, families, schools need in order to be able to give first-class care to someone experiencing their first episode psychosis, and if done properly, can really mitigate the lifelong impairments that psychosis can have, not only for the person experiencing it, but for their families and friends as well. So a little bit about first episode psychosis. As Emily said, this is a model that really looks at early detection and intervention for psychotic disorders, specifically more kind of traditional psychotic disorders, not you'll see some of the out of scope in a couple slides later. So this isn't a model for everything, but it is a model that works for the right people. And really, the evidence shows very clearly that there is a very critical time from when the symptoms first become apparent to when you get care that has a big impact on how well someone does through the course of their life. As you see on the slide, the WHO recommends that we start within 90 days of symptom onset. Now, that's ideal, but starting as soon as possible is what we're targeting. Next slide, please. So coordinated specialty care is the model that is considered the best practice in the industry. It's recommended by the American Psychiatric Association, as well as the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the National Institutes of Health. So very highly regarded. It's recovery-oriented, which really means that we're looking for patients and their families to be able to look towards maybe not completely, sorry, my dog just jumped up here, not complete recovery in the terms of if you have a broken leg, but recovery in terms of how we, in the behavioral health world, we are hoping for. It's very multidisciplinary, team-based approach is really key. The other thing that it emphasizes is that there's shared decision-making, not only with the individuals, but their families as well. And it's very, very much tailored to the individual, where there are some, you'll hear from the Harvard Review team, some protocols. They really do need to be customized for the needs of the particular patient and their family. The core concepts are here with a big emphasis on family education and family support, on really supportive employment, making sure that we're optimizing the life for the person who's experiencing psychosis, and peer support, and what that looks like and how that is something that is also essential. The other thing that's essential about this particular model is that you need to have the same coordinated team, and they need to be trained in coordinated specialty care. So this isn't something where you can do group therapy in one place and case management in another. It really needs to come together as a core model. Next slide. In our work, we made focus areas, and this is traditionally what happens when we do our Bree work. In this particular subject, we had 3 areas. One, early detection and rapid access, as I said, is super important that we detect quickly and we get care as soon as possible. So we talked about components of that. What's the evidence say about how to do early detection? Who should do it? Where should it be looked at? How can we make sure it's as easy as possible to get into coordinated specialty care? And what kind of community engagement and education guidelines really help with that detection and access? Had a lot of conversations about treatment, about the coordinated specialty care treatment guidelines, but also considerations for people who either don't meet the criteria for CSC, but are experiencing some symptoms of psychosis, or have other considerations that are more complex than what is traditionally cared for within this model. So if you have a substance abuse condition, if you're on the spectrum, this model hasn't really been tested very well for that. But we do speak in the guidelines about what some other options are. And then again, the last part of our focus areas is really about transitions of care. Community specialty programs are not, or coordinated specialty programs are not intended to be lifelong programs. They really are 2 to 3 years in general. So we had lots of conversations about what happens as the person is getting ready to transition into a different kind of care, and what should that different care look like. Next slide, please. We created guidelines for several audiences, and this was very fun to do. we had such great experts on our work group, and we're really able to bring in the best in the industry to give us different ways of thinking for all these different audiences that are really important in identifying in particular and providing access. Today, you will hear from the Harborview people from the behavioral health perspective, and you'll hear from one of our health plans. Next.
Thank you so much, Darcy. We'll go ahead and invite Dr. Mike Franz forward, who will be talking about health plan perspective. He is also a clinician who works directly with this population to share a little bit more from the health plan perspective of how they are utilizing these guidelines. So I will pass it to him.
Thank you, Emily and Darcy. It was a real privilege and a pleasure to participate as part of the work group. My colleague and I, Siobhan Mraz, we really learned a lot throughout the process, and just the opportunity for health plans and providers and experts in clinical models all coming together for the betterment of the people of Washington. It was just a great project, and I'm glad to see that we came up with a concrete product with these guidelines. And today I'm just going to briefly go over about 6 of the specific health plan guidelines. These can be found on page 15 of the actual report. There's about a dozen that specifically apply to health plans, but just in the interest of time, thought I'd focus on 6 and give you all a little bit of a window into how a health plan, in this case, Regents Blue Cross Blue Shield, is really implementing these, or to the best of our ability. There are obstacles, there are challenges, there's also some great opportunities. So I'll just go over, as I said, about 6 of these and give you a little peek into what we're doing. So the first one is the guideline that we create an internal system to flag members that receive a new diagnosis of schizophrenia spectrum disorder or another psychotic disorder. And at Regents, and I know our Primera friends have this too, we have a value-based integrated care management program that really focuses on our members that have very high significant behavioral health complexity, but also perhaps some medical complexity and some social determinants of health complexity. They'd also might struggle with navigating the complex health delivery system. So as one of our criteria that we have updated for this program for 2026 and going forward is a flag for having been discharged or even recently diagnosed with a schizophrenia spectrum disorder. And we'll review those members to see if they might be appropriate for this intensive care management program, which, as part of what we can do, is connect those members to CSC programs that are available in Washington and that we have contracts with. And I'll speak to that latter part, which is pretty important, in just a moment. So that takes me to the next bullet, which is routing to case management team for outreach and connection. Certainly, if they meet the other criteria we have for our VBICM program, that's the care management program, and those folks will be the ones to get them connected to appropriate care, like first episode psychosis treatment. But in the case where maybe they're not appropriate for the VBICM program specifically, we'll still have care management team review those cases. We're setting up a flag right now in our system for when that claim, that first episode psychosis claim with that diagnosis attached, hits the system, so that our care management team and others in the organization can reach out and help that member get connected to appropriate FEP. This third bullet is very timely. It actually became a huge priority, quite honestly, transparently, after the guidelines were published. But this is where we need to outreach to a member within 1 week of discharge for first hospitalization psychiatric concern, and to encourage follow-ups and try to connect that member to care. So similar to the previous bullet, but it has a specific 1 week time frame when leaving higher level of care, such as psychiatric hospitalization. Now, we do have non-clinical care advocates at Regents who do reach out at discharge to all members leaving a higher level of care when those higher level of care facilities have an ADT feed, or automated data transmission feed. And unfortunately, a lot of standalone behavioral health hospitals and higher levels of care actually aren't in that system. So we have to figure out other ways to do that. And we recently found that we've been underperforming on the HEDIS FUH follow-up after hospitalization metric, which is essentially this requirement that we get our members connected to care within 7 days. Not just guide them to care, but it only counts if they actually have an appointment. So we have major strategic initiative in this place for 2026, where we're going to be working very closely with our higher level of care psychiatric providers in Washington State and elsewhere, such that when our members hit the facility on the day of admission, we will be working very closely with them to get them connected to appropriate outpatient or lower levels of care in that first week of discharge. And we're developing those workflows, we're developing those relationships and doing that provider education currently, and hope that this really does move the needle so we can improve our performance, not only on this HEDIS metric, but ultimately to get our members better care and better outcomes. All right, next slide, please. All right, this is my final slide, so just 3 more. The next guideline I wanted to just talk about and share what we're doing is maintaining and publish a list of CSE providers within the network that are easily accessible to members within time and distance standards. So, transparently, we don't yet have specific contracts for CSE in Washington State. But I'm going to speak to more about what we're doing in that space with the last bullet on this sheet, on this page. But we are currently in the evaluation stage of building out how are we going to get these folks into our digital directory. That's what most members are utilizing these days to try to identify what options are available for them with their health plans. This will involve our digital team, provider enrollment, even our credentialing team. We're currently vetting our community mental health plan partners in Washington State. We have a project underway where we want to see, number one, are we contracted with all community mental health programs in Washington? I think we're contracted with most, if not all, for what services, and then really look and see where those gaps are in those services, likely including CSC, and then prioritizing closing those gaps. In regards to time and distance standards, we use the Insurance Commission standards for that and anticipate that those would be the same for CSC going forward. If those somehow get modified or are different than what's currently out there, then we'll, of course, meet those standards as well. The next bullet or guideline is train member-facing staff and therapeutic communication approaches, including trauma-informed care, motivational interviewing. So I'm pleased to say that our behavioral health care management clinicians have a training and curriculum entirely developed, inclusive of trauma-informed care, motivational interviewing, that we provide when we onboard our new BHT members, clinical and non-clinical. And then we also provide this training to our member-facing customer support specialists. Those are the people that answer the phone when you call the 1-800 number on the back of the insurance card. The final bullet, and this is really where I think the rubber meets the road for health plans in this space, is moving towards an alternative payment model structure. This is really required to render this model effectively, comprehensively, and to reimburse sustainably. Fee-for-service doesn't really meet the need. In fact, the reality is that commercial health plans like Regence, by and large, don't reimburse currently some fee-for-service components of the model. Now, we would like to do that, and there's a lot that goes on to get those services covered. But one thing we can do is move to an APM, a case rate, that would just holistically cover the various components of the program that Darcy went over, and use that case rate for at least for the first several months of treatment, use the appropriate codes to do that, and then perhaps use a fee-for-service mechanism that's more flexible to ensure that those members can continue to get the appropriate services after those most intensive months of treatment are completed. So working with Emily and the Bree team, they've been very helpful. They're actually working with us to identify where we have high volume membership. Kind of, we have a heat map of that, and then looking at specific community mental health programs that are offering CSC or other systems that are offering CSC. And in Q1, we'll be reaching out to one or more of those specific CSC providers to see if they're interested in initiating contract negotiations with us so that we can fully cover these services and sustainably reimburse them. So we're looking forward to that work that will be starting very soon. Thank you.
Thank you so much. We really appreciate that. Before we transition to the next speaker, I just wanted to give you a chance to kind of talk about and switch hats here for a second. I know you also serve as a clinician and work directly with this population. Earlier, when we heard from Darcy talking about the focus areas, we talked a little bit, or she mentioned kind of like the autism spectrum and working with individuals with that. Did you want to provide a little bit of comments of kind of how considerations we may need to take for individuals on the spectrum who might be experiencing first episode psychosis that you'd like this group to know about?
Sure. Yeah. All transparency, I live in Central Oregon, so I'm not a Washingtonian, but I do contract to our two largest pediatric primary care clinics, do the collaborative care model that the AIM Center in your good state developed, and e-consults as a child psychiatrist for those organizations, and can cover up a population panel of about 35,000 folks. And then in the afternoons, I go into our community mental health center, Deschutes County Behavioral Health, and I run a neurodevelopmental complexity clinic for kids that many of them do have more severe autism or other developmental delays, genetic syndromes. And I'd say, first of all, it's super complex and clinically challenging sometimes just to tease out what is an independent psychotic process that might be developing. Is this new onset or first episode psychosis? Or is this part of the autism syndrome or other developmental delay that really requires a different approach than more of a CSC type program? But let's say I get through all of that and identify, I do think we actually have a de novo onset illness. Beyond that, well, then having the concurrent autism spectrum disorder can be very challenging in how a CSC program, let alone any program, would engage that patient in treatment. So I would strongly encourage that a CSC program kind of have a neurodiverse track in place where there is some expertise to work with those members a little bit differently, and to be able to meet them where they're at and specialize in those specific. There might be some additional social challenges, not that first episode psychosis doesn't have sometimes some impairment on ability to socialize, but I think there's some unique parts of the presentation and the combination with the ASD diagnosis that would behoove us to really pay attention to that as we develop the clinical model, and would love to be a part of that somehow.
Thank you. I appreciate you providing some comments on that. We will now transition to learning more about how work is done at a behavioral health agency. So I'll invite our speakers from Harborview to come forward.
Thank you for having us. So again, my name is Sunny. I'm the Director of Outpatient Behavioral Health at Harborview Medical Center, and I'm joined by Allison Schwartz, who is one of our social workers and IRT trained therapists for our First Episode Psychosis program. Our program is called the Specialized Treatment for Early Psychosis. STEP is the acronym. Next slide, please. I will kind of piggyback off of what Darcy was saying. I have been incredibly impressed with this collaborative, and really appreciate the guidelines that have been developed. For us, we are a full CSC first episode psychosis program. And so I have to say it was a little easier for us to kind of fit our program into these guidelines, because we're essentially doing all of this as this type of a program. So for early detection and rapid access, we have close engagement and connection with the community. Frankly, we don't need to have that much engagement at this point because we are getting enough referrals that are coming from both outside, either from our inpatient psychiatry unit, community behavioral health agencies within our area in King County, Washington, as well as New Journeys, which has a referral process that's very simple for people to access off of their website. You can just refer someone from there, and they will connect that person with one of the New Journeys programs that are located within the state of Washington. We do a lot of community education that's in partnership with New Journeys and the King County Integrated Care Network to really get the word out about the programs that exist in our area and across the state. And as I said, close coordination with inpatient psychiatry units, including children's, primary care and community behavioral health programs. I think also the standard around quick access and really reducing delays in access to care. This is just a little snip from our Epic electronic health record showing that currently we have 3 days to schedule patients that are being referred to our program, which has been something we've been very proud of. The process is simple. People get referred. They are scheduled to meet with our clinical director, lead person who is also the family education specialist, who will do a quick kind of screening just to make sure that a person meets, basic criteria. And then we'll get them enrolled in the program. So it's a very quick process for people to gain access to services. Next slide, please.
Yeah, I think we've also already heard from Darcy and Mike the importance of making sure that with coordinated specialty care and in this specialized program that we're accepting clients who are a good fit for our program. So this is just kind of a little bit more information on our side of what we're looking for with admission criteria. A lot of times when people are referred to us, it's so early on in their symptom presentation that they're coming in with just a diagnosis of psychosis unspecified or things like that. But we are dealing with a wide range of schizophrenia spectrum disorders. And we recently have been able to also accept bipolar with psychotic features within the last year. Similar to what Mike was saying, a lot of the most common diagnoses that we might not be able to take it are when the main symptom presentation is related to an autism spectrum disorder or intellectual disability, or if it is substance or medication-induced psychosis, where the substance use is active and kind of the main leading issue. Those are better treated by other programs. And part of our intake process is that if someone comes in, we do an intake assessment and realize that they are better suited with another program, we help coordinate that care as well. So we're not, we are transitioning them to someone else. Next slide, please.
In terms of treatment, you can move on to the next slide. This is a slide that just shows the makeup of the team. We currently serve 45 individuals in our program. Typically, you're looking at a program that serves 30 people in terms of fidelity standards. We are increasing that, and we're working towards a goal of doubling the team so that we can eventually serve up to 60. But you have the medical provider. We have a 0.25 FTE psychiatrist who's on our team, as well as a resident who assists with the pharmacological treatment, med management. As I said, the family education, there's a director who also serves as the family education specialist and liaison. That's the person who's doing the general intake of any new person coming into the program, is leading the team, coordinating communication amongst the team, and then also meeting with families to provide family therapy and education, which is a real key component of this program. We have a peer support specialist who will meet with patients that are enrolled in the program, really more to provide lived experience and I guess just general education about, I've been through this myself. I know what you're going through. Sometimes it's systemic. Sometimes it's about the symptoms that people are experiencing, but they're not really providing treatment. It's really more, I would say, empathy and support, and also helping with community outreach, education. It can really be anything. If somebody needs help learning how to use the bus system, the team will help with that, including the peer. We have a full-time supported employment and education specialist on the team who does exactly that. They work with people who are enrolled in the program to really, kind of create normalization around what a typical person of that age would be doing in their life. So whether that's applying to, school, community college, universities, looking for part-time work or full-time work, really just trying to continue with those types of things that any of us would be doing in our lives. And then we have two clinicians, so Allison, and then there's another mental health practitioner we have on the team who provide individual resiliency training and cognitive behavioral therapy. This is, more of that intensive one-on-one treatment that with the person who's enrolled in services. And then all together, there's a lot of cross coordination, a lot of coverage. Oh, I'm missing our nurse. We also have a 50% nurse, which I think is a position that has not been typically included in the fidelity, but we have found it to be a key role on this team. The nurse works very closely with obviously the medical provider, but really everybody on the team, and is providing all kinds of services from, psychoeducation, nutrition support, talking about the importance of exercise and just kind of healthy lifestyle, assisting with long-acting injectable injections, things like that. So it's been key. All in all, the team works very cohesively. They're co-located in one area. They are often covering for each other. So, there's a lot of cross education around, okay, this is how I might support this family, even though I'm the IRT therapist, but I might need to jump in to support the family as well. Yeah, so it's been a really really great experience working with this team and watching how they support each other. Next slide, please. And then you can go to the next slide. In terms of care transitions, the program, typically provides services for people up to 2 years. There is some leeway with that. It's not like a hard cutoff. And so we are able to keep people in services longer if that seems to be clinically indicated or necessary. In terms of standardized transition criteria, they're looking at things like completion of identified recovery goals. So if someone comes into the program saying, I really would like to, not only be able to manage my symptoms, but also, have a competitive job or go to school, then that's how we're measuring, success for that person. And then engagement in meaningful activity so that that person really is experiencing a better quality of life. Close coordination with community behavioral health providers, including our own. We have an outpatient behavioral health agency here at Harborview, which makes it really streamlined for people in our program. The prescriber who works with the First Episode Psychosis program, STEP, also works in our outpatient clinic. So we're very fortunate to be able to transition people who choose to stay with us in outpatient services from that very specialized program into more of a step down, traditional outpatient behavioral health program. And oftentimes they can stay with the same prescriber. And then in terms of identifying and mitigating non-medical barriers, like we discussed earlier, support with transportation, education, insurance coverage. Oftentimes there will be changes in insurance coverage, especially if someone is aging out from, like, say, being on their parents' insurance to something else. So all of that support is provided by the team. I think that's it for us. Is there another slide?
No, thank you so much. We really appreciate it. We will transition to our next speaker, Carrie Nicholas, to talk about evaluation. But again, if you have any questions for our speakers, you can go ahead and place them in the chat and or in the Q&A box, and we'll ask them shortly.
Thanks, Emily. Hello, everyone. My name is Carrie Nicholas. I am the Measurement and Evaluation Manager at the Foundation for Healthcare Quality. I worked with this lovely group of people to create some documents and guidance around how to evaluate the guidelines as they're implemented across the state of Washington. So, as you heard from other organizations, there's things that health plans should do, things that providers should do. And when you look through the guidelines, you'll see that there's also guidance for employers and a lot of other kind of system level actors. So we convene a group of people from the work group in a subcommittee, and they create some helpful documents to allow that will help organizations think about how they are going to fit their evaluation in and align their evaluations with other organizations to demonstrate that the guidelines have accomplished their aim. So the first thing that we create is this theory of change. And this is really just a visual. When you are reading the guidelines, you can take a look at this and think through this buy-in period where we're creating the guidelines and people are buying into the idea, all the way through what impacts we expect these guidelines to have across Washington state. The QR code here at the right will take you directly to this theory of change, and you can also find it on our website. So this is the first document that we come up with, and we kind of base the rest of our evaluation toolkit around this. So next slide, Emily. So the measurement concepts, there's really kind of two levels. There's one, changes to the health system. So one of the reasons that these guidelines were chosen was because people were moving to Medicaid to get these services because they didn't exist in other places. So these are kind of a few high-level aims that the group identified that they would like to, or goals that they would like to see in Washington state. Most of this is going to be measured using administrative data, and we're going to get to the patient level changes next. But these are really thinking Washington statewide. Yeah, thank you, Emily. So the changes to patient care measurement concepts are things like reduction in ER usage for people who get these services, out-of-pocket costs, reduction in time between symptoms and onset, as Mike was mentioning, and increase in patient functioning. So we have some like recommended types of data sources, and we'll get to the document that these are in just a second. But these are also a wide variety of data that would be used to measure these. Yeah. Next slide, Emily. So these are really fleshed out in our evaluation framework. The evaluation framework helps define these process and metrics, helps define types of valuations, and provides lots of recommendations for design. And it's really aimed at everyone who might be doing an evaluation. We try to be inclusive. And the goal of the framework is to help, whether you are a provider or whether you are a health plan or whether you are the state of Washington, to help people align the evaluations that they're doing. So we're kind of all measuring the same thing and moving together in the same direction. And again, it is posted on our website and you can access it through the QR code there. The next slide, Emily. So the last sort of thing that we develop at the end of these guidelines are something that we call scorecards. These are the audiences here that are listed that the guidelines are aimed at, and we create these scorecards for each of these audience types. And scorecards can help with many, many things. So aside from measuring the kind of outcomes or impacts, these are really helping you measure the processes and the steps that you would go through to implement the recommendations. So some reasons that people fill them out are just that, to provide themselves with a baseline of where to start. There can be opportunities to compare your processes to other organizations to understand, whether you need to move ahead faster or slower, or if there are partners in your area, all sorts of different reasons to do that. And then the final reason that people would fill these out is because we offer awards to people who do. We would love to recognize organizations that are forwarding the Bree guidelines and implementing them into their health system or their health plan. We offer what's called our Trailblazer Award for those who have demonstrated that they have a high concordance with the recommendations. And we also have another award called the Pathfinder Award that is given to those organizations who are starting to measure their baseline and starting to plan their implementation of these guidelines. And the scorecards can be found on our website as well. You will look for them based on your audience type. So if you're a healthcare system, you'll find that there are scorecards for primary care clinics under there, and hospital systems, etc. These are very easy. They're an online form, and you just hit the submit button when you're done. It's not particularly hard. They're also savable, so you can go back to them and use them as a tool as you work through your implementation and ultimately your evaluation of your work. And Emily, I believe that is the last one that I have. And I'm happy to answer any questions about any of these documents, or if anybody needs any further direction on how to get to them.
Thank you so much. We'll go ahead and start our Q&A. So I'll ask our speakers to all come on. While they are doing that, I will pull up the first question. There's a question that came into chat that Mike, you started answering, and I'd love to kind of bring it into this space, especially to make sure others can hear it. Somebody was asking, when you mentioned that members identified as needing CSE will be provided with case management to route them to CSE, they're curious, what services will you route them for if their health plan doesn't cover CSE through existing CSE in Washington, which in our state is referred to as New Journeys. I also just want to add a little bit to this too, is there is a limited number of New Journey programs and sites in the state. So there's also a chance that individuals won't be able to access CSE just based off of their location. So I'm curious, is like both maybe their health plan doesn't cover it, but also it may just not be accessible based on the location, how you may navigate that.
Yeah, it's a great question, spot on. Top of my mind as well. I did put an answer in the chat space or the Q&A space if you want to read it or copy that.
Yeah.
But yeah, just to expound on it a bit. So, this is why I joined the work group, and apologies to people who've heard my little spiel on this, but in my provider world, I work predominantly with a Medicaid population, and with my previous health plan, we had a Medicaid line of business. And through both experiences, it's become very clear to me that commercial health plan members in the behavioral health space oftentimes lack access to some of the highest value behavioral health programs out there, usually for families and kids that have more intensive treatment needs. First Episode Psychosis is a great one. ACT is another one, a sort of community treatment. Wraparound treatment planning process is another one, oftentimes used in kids. Young adults in transition programs for those kids, older kids and young adults. And what I've seen, and again, sorry, some of my education comes from Oregon as well, is that if you are a family with a significant behavioral health condition, historically, you better darn well hope you qualify for Medicaid or you're independently wealthy. Because if you're working class and commercially insured, it's sometimes hard to access those because historically those have been provided through community mental health programs. that have historically been publicly funded through the Medicaid system or general funds. And they've kind of grown up siloed, right? I mean, done great work, but serve that population. In commercial health plans, we work with hospital delivery systems that report up to CEOs. We're not used to working with county supervised community health programs that roll up to maybe county commissioners. And then everything is very different, right? The codes that are used, the licensure requirements of the treatment team that are used, the billing processes, the way folks get enrolled, the way they access it. And I think there are some mutual barriers there that both on the provider side and the commercial health plan side behoove us to try to first assess and then knock down those barriers. And I'm very passionate about trying to get the entire population, not just Medicaid or indigent population, but commercially insured folks, Medicare population, access to those services. So I think the Bree's work here has been a great vehicle to look at what those specific barriers are. Like health plans generally don't, commercial health plans don't generally like to use HCPCS codes. Now, why is it? Well, that's a whole nother discussion. Or we historically haven't covered peer support services or voc rehab, right? Those are major barriers, and I can't, snap my finger and make all that change overnight. Commercial health plans, especially big ones, are like aircraft carriers that take some time to change course. But we do need to start moving in that direction. So my goal here, our goal is really to look at where we can compromise, come together, change the way we operate so that we broaden the population that can receive these services and also sustainably reimburse them, right? Because that's on us to figure out how to sustainably reimburse. But I think we all need to move in that direction. So unfortunately, the answer to the question is these services have been very hard to access for our membership. And we need to change that. So what do we do now? We can connect them with a psychiatric provider and a therapist. And maybe we have some community mental health plan contracts that are enough such that the New Journeys program will provide the services to the patient, our member. I don't imagine they're getting holistically reimbursed for those services, which isn't right. So we need to change that. But it's going to take all of us to do it. And I think the Bree's done a great job in bringing the key entities together to make that change. Now, it's not going to happen overnight. You heard me say what we're working on. It's going to be a process, but I think there's a real good faith effort here to make these changes.
There's a great question in the chat that I would love to kind of pose to our panel here. Are there any considerations for the BIPOC community as this population can present differently than what we've seen in literature? Has it been excluded?
I can jump in. Allison might have more to share just from her personal perspective. There is nothing I can say that is specifically different when working with a person from a BIPOC population. I can say that we have enrolled and treated many people in our program who are part of the BIPOC population, and because everything is so individualized, we've had some non-English speaking people who've been enrolled in our services, where we're working with interpreter services with other cultural competency, supports, I guess I would say. And the team has had just as good of outcomes with all populations. So it might take a little bit of creativity, a little bit of extra work on the team's part to be able to figure out how to individualize that plan, how to educate themselves more about the cultural background of that person that's in the program. But I can say for us, we've been very successful in being able to navigate that. I don't know if that really answers the question that well, but just really providing more, as an individualized plan as possible for each person in the program, which I think is one of the benefits of having such a robust team that is supporting such a small number of enrollees.
Yeah, and if I can just jump in quickly there, I think you summarized it well, Sunny, but I think There's also just a little bit of nuance when it comes to psychosis and how we're interpreting people's presentation, and really wanting to make sure that we're not viewing cultural elements as symptoms. And so we just have a lot of care in terms of, especially with the family support, we can get a lot of really great collateral information on what about the person's presentation is within their cultural norms or their family norms or kind of how they have been before their baseline. So I think that coordinated care also really helps with that aspect to allow us to have a really collaborative approach. I also just wanted to share there was Psychosis Care is a conference that happens every year, and last year they had a really interesting speaker on kind of the history of psychosis and how that's pathologized different groups. So I would just recommend looking into that as well for more information on that.
Thank you. There's a question that, Darcy, I wonder if you want to come on and answer, that came through. Said, did participants examine the alternates to hospitalization for first episode psychosis?
There we go. Sorry. So Emily, tell me that again.
Yeah, the question was that did participants, did the work group examine the alternatives to hospitalization for psychosis?
We didn't really focus so much on that. It really was mostly about, from the hospital perspective, about identification of the symptoms and then accessing treatment, because most first episode psychosis treatment really is outpatient focused. But that's a great question.
Yeah. And then Carrie, do you want to elaborate with your comment too?
Yeah, sure. So in our framework, we often put kind of strong and soft recommendations to different types of organizations that are conducting evaluations, and we always do put in there the kind of a caveat that they should look at different groups of people by different social factors, especially when you're looking at access to programs and things like that. So I would say that is one of the things, but as you heard from everybody, it's really difficult to make recommendations in terms of identification. That really should be left up to the clinician, and clinicians can make a decision when they're evaluating their own success, whether or not they want to use certain criteria and what they want to use.
I have a question for our work group members is, after supporting the creation of this report, what about the report are you most proud of? So I don't know, Darcy, if you want to start us that question. Oh.
Sorry about that, having clicker problems. One of the things I really enjoyed about this work group was the degree of expertise that the panel had, and the way we pushed ourselves to think about, in particular, the transition aspect of first episode psychosis. And that was a conversation that I think it took us a little while to get there, but in the guidelines, I believe that there, it is good content in there to guide anyone that's in this work. And also, just shout out to Mike. I think the conversations we had with the health plans were surprisingly delightful, and the interest in figuring out how to pay for this, because right now, honestly, most of the, and Sunny and Allison can speak to this, most of the people who are able to access the treatment are on Medicaid. In the commercial sector, it has been had a little more difficulty figuring out how to pay for it.
Yeah, I would second that, Darcy. And again, same shout out to you, Mike. And I might want to connect with you later separately. But we have definitely, at Harborview, we are able to accept individuals with commercial plans into our program. But to your point, Mike, the reimbursement process is not nearly as comprehensive. And so, oftentimes we find ourselves having to limit the number of people that we can accept. But there is hope, because we have been engaging in a lot of conversations across, within our own network and across the system about how we can improve that process. Because as you can imagine, most people are coming to us who are still on their parents' insurance because they're young. And we certainly do not like to encourage people to get off of a commercial, payer plan and switch to Medicaid if we don't have to. So.
Yes, and I think that's a newer issue, right, with the ACA and young adults staying on their parents' plan. Probably historically before that, those folks generally weren't commercially insured, and now that's what they have. So
Right.
to change it, we'd definitely like to link up with you and any other New Journeys providers out there that are interested in considering a pilot of a commercial contract. I was really proud of the rigor of the conversations and kind of the fearlessness I think we all took there, but yet remained respectful. I think Emily and Beth and the team, I remember clearly they invited a national speaker who's a strong advocate for these programs and really challenged me into health plans as to why we can't do things differently. And, that caused some good conversation. I think maybe some enlightenment on all sides about what some of the challenges are, but let's roll our sleeves up and try to figure this out. And I just think people coming together at the table all had really good intentions, all saw the patient/member in the center as the reason why we're here to do this work. And in that way, it felt very aligned, and I was proud of that.
I really appreciate you bringing for any answer, but really highlighting that piece. I think that's really where the Bree Collaborative serves, is we recognize that there are a lot of silos within the healthcare ecosystem. So we enjoy kind of bringing representation from across the healthcare ecosystem together to really talk about how can we utilize our strengths to improve the overall outcomes for that person in the center being the Washingtonian, and potentially kind of push each other to grow and ask them to kind of see what more you can do, but also that learning piece of sometimes we like to think that one group can do something, and then through conversation, like, oh, I didn't realize there's these other things involved. And I think that's just like a really important space to learn together, grow together, but also understand each other better. As we all are pursuing, I like to say, a happy, healthy Washingtonian at the end of the day. I think we'll just wrap up with one last question, which is, what is one takeaway from this report or attending the webinar today that you hope someone has?
I think for me, the thing I loved most about this report is there's something for everybody, regardless of what area you're coming from. And it seems, it's very comprehensive and it's very simplistic, not in the meaning, just meaning like it's easy to apply to whatever area you're in. So you can start with small things and grow from there. It doesn't feel overwhelming when you read this report. So that's the thing that I think would be the takeaway for me for anyone, regardless of what area you're coming from.
Emily, I will pop in and say I hope that the takeaway from this webinar is that there are continuing resources to implement and evaluate this work if people are deciding on pursuing it, and the Bree is always open to helping, and we have lots of resources and opportunities for them to do that here.
And I hope that we all kind of note who all was here, and maybe keep this list if we can have the attendees and share that. And I think we all are like-minded, and maybe there's opportunities for us to collaborate further.
And Darcy, if you're still on, do you want to add one more comment?
Sure. And sorry, I don't know why my camera's not working all of a sudden, but I just want to, I hope that this webinar really showed the audience the breadth of work that was done and the steps forward that we now have available as a resource in our community and beyond for those that are really interested in doing good work for this important population.
Well, we want to thank all of you for being here today and for participating in the panel. If you have a minute, it'd be great for you to please complete our post survey just based on your experience being with us today. We also have a handful of different events coming up that we want to invite you to join us to. So we've added those to the chat and we'll send those out. But we really want to send and end with a big gratitude. Thank you so much to our speakers today, but also our work group members in crafting this report. We really appreciate you sharing, again, your time, knowledge, expertise with us. It's because of you that we're able to make these reports, and we are really excited to help disseminate them and share it within our network space. If there's any way the Bree Collaborative can support you in implementation or evaluation of utilizing our report, please let us know. But we are so grateful for all of you to be with us today. We hope you have a great rest of your day.
Thank you.